everyone for joining us for the April 2022 edition of BrainX Community Live. We are joined by two endocrinologists who are going to talk about AI applications in endocrinology today. But before we get to that, I want to give an overview of BrainX Community for those who are joining us for the first time. So three years ago, we started this platform with the idea of machine learning in healthcare for good. We have grown to have 4,000 plus international members. We have a very strong LinkedIn group of 2,000 plus members who actively share scientific information, community programs, collaboration opportunities. You can visit our website to look at all the content, and I'll go through that briefly in the next few slides. Our website is brainxai.org. And just like today, we hold our monthly live sessions over here, trying to bring in experts from different fields to talk about their work and to help us understand what's going on with AI applications in their different areas. So this is our website. We changed it a few months ago, so it's way more user-friendly. Please join us if you haven't. On our homepage, we have the updates section where you can find the latest updates that have been made to the website. There might be an article that is posted that is of interest, our podcast, or it might be related to a new data set or an upcoming live session. So go to our update section to stay tuned. We have the Connect segment. This is where we post all the information regarding our upcoming live sessions and also the ones that have been recorded. And we provide direct link to our YouTube channel through this. So you can subscribe to our YouTube channel, or you can go to the Connect section to look at all the prior meetings that we have had and listen to all the speakers who have presented their work. As I mentioned previously, we have a very active LinkedIn group. We share a lot of scientific information over there, meeting opportunities. So please join us on LinkedIn to stay active there and get information in real time. We have our Learn section on the website itself, where we provide a curated list of articles. So these articles are, or I should say, links to the articles. These articles are selected based on high value or something that our readers might be interested in to learn about AI applications in healthcare. We categorize them for different specialties that they might belong to. So you can actually filter, as shown on this website photograph. You can filter them for your specialty of choice and find articles related to that. They are linked, they are categorized, and they're readily available to you. Journals are also available right through the Learn section. So if you want to look for journals which are providing good content or good articles related to AI in healthcare, and are specifically focused on that, you can filter the Learn section by journals and you can find that. We also started a book section, so you can filter on Learn by book and find some of the real good books related to AI and healthcare right there. Something that we are all looking for all the time is data. So we have the largest repository of links to open source data sets right available through our data section on our website. Again, these are categorized by the specialty that data belongs to. Sometimes it's multiple specialties, and you can click on the link over there and go to the data set directly and then request access. We also have a podcast series where we feature some of the experts from around the world, and you can listen to their experiences and their vision for the future. It's BrainX Talks. It's also available through all the different podcast mediums like Apple, Spotify, or Google Podcasts. So please subscribe us and get the latest podcast delivered right to your smartphone or your listening device. And of course, with the COVID pandemic hopefully winding down, there is a great opportunity for us to reconnect, to figure out opportunities to network and collaborate. And I'm sure you're looking forward to some of the meetings again this year or in 2023. So these meetings are listed in the meetings or the conference section of our website. and you can find the meeting of your interest and you can join us or connect with us over there. Earlier this year, thanks to Johnson Thomas and Chaitanya and many others, we published our 2021 year in review. And what I've highlighted over here is that endocrinology as a specialty, similar to other specialties, has been growing in research and publications year over year. It's growing. There are some key areas of growth that, again, Chaitanya and Johnson Thomas are going to talk to us about. But there's some really impressive work going on in that area. So I would like to welcome our speakers, Dr. Johnson Thomas, who is a board certified endocrinologist and the section chair of Mercy Endocrinology at Missouri. He's an avid coder. I learned a lot from him at a recent meeting. He developed EndoTools, an iPhone calculator app for endocrinologists. And he's also done a lot of work around prediction of thyroid malignancy. And recently his work on AIBX was published in the Thyroid Journal and has received a lot of great reviews. We're also joined by Dr. Chaitanya Mamillapalli. He's also an endocrinologist and the section chair of Springfield Clinic Endocrinology, Springfield, Illinois, and is the founder of Care Health AI, which is a diabetes decision support platform to optimize clinical outcomes. He's an AI clinical research scientist and is currently the vice president of the Academy of Physicians in Clinical Research. So thank you both for joining us. And we're looking forward to a great session from both of you. We will start off with Chaitanya. So Chaitanya, I'm gonna stop sharing my screen, allow you to make your presentation, and thank you.
Sure. Okay, thank you for that introduction, Piyush. So I'm going to review today regarding specifically AI applications in diabetes care. As Piyush has mentioned, there's an exponential growth in the field of AI and diabetes in the last decade or so. In 2007, the number of publications in AI was in the 2,600 range. In 2017, there were more than 10,000 publications. The number of these publications can be primarily categorized into 5 categories: area of early diagnosis of diabetes and pre-diabetes, patient self-management tools, clinical decision support systems, diabetes phenotyping and complication prediction, and diabetic retinopathy screening. I'm going to review representative examples in each of these areas, and we'll discuss about some of these applications in detail. This is a small study that was done by Stanford researchers in healthy volunteers. They studied the glucose levels, what would happen in glucose levels in people who do not have diabetes and pre-diabetes. They placed CGMs on these patients and monitor their blood sugars. To surprise, they found that despite not having any diabetes or pre-diabetes, there were significant elevation in blood sugar levels. And based upon the severity of blood glucose spikes, they were able to classify these volunteers into 3 categories: low variability glucotype, moderate variability glucotype, and severe variability glucotype. And a notable and concerning finding from the study is about a quarter of these patients had severe variability glucotype, indicating that they had blood sugar excursions which are really high. So if we were to use just the standard of care definition of A1C more than 5.7% to diagnose pre-diabetes, we're going to miss a lot of these patients. And also 80% of the patients had elevation in blood sugars above 140 just by eating a standard morning breakfast meal of cornflakes and milk. So this tells us that probably there's a role for CGM and using AI modeling techniques to diagnose diabetes and pre-diabetes early and target them for lifestyle interventions. There are several machine learning models that were studied to evaluate the patients for risk of type 2 diabetes, and their accuracy in the studies was in the 80 to 90% range, which is superior to what we typically get with risk factor-based prediction models. This is a schematic diagram about clinical progression of diabetes and pathophysiology of diabetes. Unfortunately, because of suboptimal screening rates, a lot of patients with diabetes and pre-diabetes remain undiagnosed. There are around 7 million patients in the US who have diabetes and do not know they have diabetes. Similarly, there are 70 to 80 million patients with prediabetes. They are not aware about diagnosis of prediabetes. So by the time patients are diagnosed with diabetes, about 50% of the pancreatic function is already lost. So we can use machine learning models to deploy them on electronic medical record data and screen patients for diabetes and pre-diabetes. So we can diagnose this condition at an earlier stage and target them for lifestyle intervention changes and halt the progression of diabetes. This is one way of how we can prevent the diabetic epidemic from taking over the US. And there's a doubling of prevalence rate of diabetes by 2030. So we need to ensure that we use these models to help with that. Before we implement such models in clinical practice, we need to understand that a lot of these studies were done on retrospective data. We need to prospectively validate these models and ensure that they are doing, they're giving valid results before implementing them in clinical practice. There's a lot of studies, there's a lot of developments in the area of patient self-management in diabetes. This is a study that was done in Israel to look at how we can optimize post-meal high blood sugars in patients with diabetes. So typically when patients have diabetes, we give them generalized recommendation, like try to restrict their carbohydrates, not eat snacks between meals. So this is sort of a generalized recommendations, and it's not personalized to each individual. And because of this, the adoption rates and the adherence rates of dietary recommendations is low. What the researchers did in this study was they studied 800 volunteers, and they found what are the factors that influence the patient blood sugars. So one of the things they found was the gut microbiome, and they used decision tree machine learning models, and they found that gut microbiome has significant impact in predicting blood glucose levels. So you can technically give a patient list of foods that will make the blood sugar go up high in that particular patient, and that will keep the blood sugars in a stable rate. So you can sort of personalize a diet plan rather than just saying a generalized recommendation. You can personalize diet plan to that particular patient based upon the gut microbiome. The researchers have commercialized the technology, and they had started a startup called Day2. Technically, you can send them a stool sample, and the company would pop out a personalized dietary recommendations of different varieties of foods which are good for you and which will cause blood sugar spikes in you. So this is a great example where AI modeling techniques can be used to personalize nutrition strategies. There's a lot of developments in the space of artificial pancreas, which is really had a tremendous impact in managing patients with type 1 diabetes. Hybrid closed loop is the first iteration of the artificial pancreas system. In this, a continuous glucose monitor is integrated with an insulin pump to guide the insulin dosing decisions. This is based upon traditional control engineering algorithms, and it still requires user input, like how much carbohydrates they are taking and what is the physical activity. And because of this, it's still not completely autonomous. Contrasting to this, a fully closed loop system is where the CGM can talk to the insulin pump, and using AI modeling, they can automatically predict how much patient is eating and what if he's physically active, on all the previous insulin dosing scenarios to automatically adjust insulin dose without any user input. So this will give more independence and autonomy to the patients, and it's great. It'll be great for the patients when this comes into fruition. The hybrid closed loop systems are already available in the market with Medtronic, Tandem, and Omnipod, which was approved recently, and closed loop systems are currently in development. CGMs have revolutionized regarding how we help patients with type 1 diabetes, especially by their ability to predict low blood sugars. The diagram here on the left side shows a threshold-based alert system where the continuous glucose monitor is measuring their blood sugar continuously, and it alerts the user or the patient when the blood sugar drops to the less than 70. And even when the patient corrects this hypoglycemia in the right time, he or she is going to spend some amount of time in hypoglycemia. So the hypoglycemia is better, but still is going to spend some time in hypoglycemia. On the contrast, by using a method called predictive alerts, by using AI modeling techniques, hypoglycemia can be predicted 1 hour in advance. And this will actually help the patient to preemptively treat hypoglycemia before the hypoglycemia actually happens. So thus avoiding hypoglycemia altogether. This is already available in the continuous CGMs that are already available in the market, the Dexcom and Freestyle Libre, and it has tremendously helped patients with type 1 diabetes, improving their quality of life, decreasing the amount of time they spend in hypoglycemia range. A more robust patient safety system can be created by integrating all the data sources, including the CGM, insulin pump data, their dietary intake, their physical activity, and which can have the ability to predict high and low blood sugars several hours in advance, and can also predict nocturnal hypoglycemia episodes as well. As I mentioned before, controlling post-meal high blood sugars is a challenge. In patients who are on mealtime insulin, how to dose the right amount of insulin to ensure that the patient does not have high blood sugar after the meal or low blood sugar. If you give them too much, they're going to have a low blood sugar. If you give them too less, they're going to have a high blood sugar. So typically we use an approach called insulin to carbohydrate ratio, where we dose the patient humolog based upon the carbohydrates they're consuming. Unfortunately, this is not a perfect approach because each patient is different. They react differently to the same carbohydrate. And also, patients are not that versatile with counting carbohydrates. So there's a technique called case-based review where the system will actually look into the database for insulin dosing scenarios in the database, and then it can retrieve the most similar insulin dosing scenario that will be applicable to the current situation, and they can guide the patient to give the appropriate insulin doses. So they'll retrieve the insulin dose, and then based upon the situation, that the system will recommend the appropriate insulin dose. And it will measure the impact regarding how the insulin dosing regimen has worked in that particular patient. If it works well, that's good. It's going to be adapted to the algorithm. If a modification needs to be done, then it's going to take that into consideration. It's going to modify, and that's added to the algorithm as well. So there's going to be a database. It's going to be retrieved, reused, and revised. So the system gets better as the time goes by. And this technique was studied in a small pilot study, and it showed good results with keeping the blood sugars in good range. GoCarb is a mobile app which will help patients to count carbohydrates just using their smartphone. They can scan the food and be able to estimate the amount of carbohydrates that is there in the food. And this is a really cool app. A lot of patients are not, they have difficulty understanding the concept about carbohydrate counting, and it's very difficult for them. So using an app like this, they will get the carbohydrates, what they're going to consume, that can help with dosing their mealtime insulin. In the small pilot study, the accuracy of the GoCarb was compared against a visual estimation of an expert dietitian, and they have comparable results, which is promising. There's a large amounts of data in the electronic medical records, and AI models can be used to draw the value from them and personalize treatment plans. This was a research project that was done at University of Utah. The system was developed on real-world EHR datasets, and the model name is called Treatment Pathway Graph. It would evaluate the patient's data and do sort of a predictive modeling and pop out the treatment recommendations. What are the different treatment options? What would be the risks of the treatment? What would be the benefits of the treatment? They also include the costs of the treatment. So all of that is available to the patient, to the physician, and he can share with the patient in real time at the point of care. So having all this information on one screen and ability to have this conversation with the patient about the risk, benefit, cost is going to make sure that a lot of patients are going to receive standard of care. It will decrease the cognitive burden on the physician. It will also empower patients to play a more active role in their healthcare. So this has a lot of potential. There's a lot of studies that were done to predict risk of diabetes complications. This was a large administrative claims database study that was done in Ontario, Canada, on 1.5 million patient records. The models were able to predict complications of tissue infection, retinopathy, and cardiovascular disease, and amputation risk 3 years in advance with a sensitivity of 70 to 85%, which is really good. In the same study, the researchers did a cost analysis, and they found that the annual cost of diabetes care in Ontario, Canada was $4 billion per annum. And by capturing the top 1% risk of patients, they found that they were accounting for 11% of the annual cost. And they captured top 3% of the high-risk population. That population was accounting for 22% of the annual cost. On the contrast, if you just use 1% and 3% randomly, you'd only capture 1 and 3% of the total annual cost. So using this approach at a systems level, at a population level, the government can probably do targeted interventions like community programs, subsidized food, subsidized healthy food, and also incentivize physicians to provide more close follow-up care to these high-risk patients. Eventually, this is going to improve the outcomes at a population level and will also decrease the cost of care. This is a great example of where a data-driven approach can be used in population health to improve outcomes. Diabetes is a very heterogeneous disease, and typically at the point of care, a physician is not aware regarding what that particular complication the patient is predisposed to. By using AI modeling, patients can be categorized into different phenotypes and see if the patient is predisposed to a particular complication. Say, for example, if the patient is predisposed to a higher cardiac complications, they can be put on the appropriate medical treatment like GLP-1 or SGL2. On the contrast, if they're predisposed to a progressive renal disease, they can be on SGL2. So AI modeling can be used to risk stratify patients and identify patients who are at risk for certain complications and to do targeted medical treatment, which is personalized to that patient. Diabetic retinopathy remains a leading cause of blindness in the US, and the screening rates for diabetic retinopathy is not optimal for several reasons. IDXR is a FDA-approved deep learning algorithm system which can screen diabetic retinopathy using the retinal images. In the pivotal study, the accuracy was really good with sensitivity of 87% and specificity of 91%. So this is a great example where the AI models can have already impacted a lot of patient care. Despite the promise, there are a lot of challenges that remain, and these are not specific to implementation of AI models in diabetes care. It's more generalized, but also applicable to using in diabetes. There's a lot of variety of electronic medical records, apps, medical devices, and interoperability between these different systems is a significant barrier. There is a lot of cost and effort involved in development and deployment of AI models. And the main benefits of this is early diagnosis and the prevention of complications. When healthcare systems or leaders are making decisions, are allocating budgets, the benefits that happen with these AI models are going to happen in the long-term horizon. So there's no immediate return on their investment. So it's difficult for healthcare leaders to put a lot of money into systems which does not pay off immediately. So that's going to be a significant barrier for adoption. There's limitations of data. As we all know, EHR data is not accurate. There's a lot of data which is not good. Also, a lot of data is buried in the unstructured data. And AI models are only as good as the data it's trained on or data is going to be deployed on. So before we get a good use of the AI models, we need to ensure that we have robust data sets and they're in a structured format. There's also issues regarding design problems. A lot of the AI models are done on retrospective data that need to be prospectively validated before implementing in clinical practice. Also, unsupervised learning algorithms will have concern regarding black box. And because of this, there is less trust from the physicians, and that can decrease the adoption rate. So this needs to be addressed. So keeping those limitations in view, that's where we started my startup carehealth.ai. About 75 patients in the US do not, 75% of patients in the US do not reach their treatment goals for their lipids, A1C, and their blood pressure. So how do we move patients to reach their target goal? And how do we improve the adoption of evidence-based guidelines, moving the evidence-based guidelines from research to the bedside? So that's the main goal of this platform. So we're still in the earlier phase of developing the prototype. So the overview of the platform, the model will analyze the patient data and will do a sort of a phenogrouping and will pop out evidence-based treatment recommendations, integrating the cost of care and their insurance information, and automate documentation for the physician to decrease their work burden. So if there's any opportunities for data collaborations, please contact me. So in summary, AI is going to cause a paradigm shift in the way we manage diabetes through data-driven approach. But before we implement in clinical practice, we need to ensure that regular standards are established to address the issues of accuracy, reproducibility, bias, safety, and privacy. A team approach between physician researchers, data scientists, software developers, and healthcare leaders is critical to make sure that the AI applications perform well in real-time clinical settings. Thank you for attention. Thank you, Piyush, for giving this opportunity. If you have any questions, feel free to contact me at my email. Thank you so much.
Thank you, Chaitanya. That was very impressive. And despite me trying to keep up with all the literature, you summarized it so well that within a few minutes, I was able to get a 30,000 feet view of what's going on with AI. And it's really impressive. So a lot of people talk about the challenges with implementation of AI in healthcare, but here you showcase some of the real life tools that are available, which I think a lot of people are not realizing because they work behind the scenes.
Sure.
So say, for example, the app that you mentioned that does the carb counting, what many people sometimes don't realize is that it is using AI to do that. It may not be advertising it in a big way to state the same, but there are, from your presentation, what I learned was there are great real life examples of AI applications that are already out there. And congratulations on carehealth.ai. That sounds very promising.
Thank you.
And I'm sure some of the people who have joined us or will view this later on will contact you and will have collaboration opportunities with you. So thank you very much for presenting this, Chaitanya. And I know you have to be somewhere, but if you have any questions, I'll make sure that we pass those on to you. So thank you for your presentation.
Thank you so much, Piyush. Thank you, everyone.
All right, with that, we will move on to our next speaker, Dr. Johnson Thomas, who's going to talk about, again, another important part of endocrinology, which is thyroid disorders. May not be as prevalent as diabetes, but very, very common.
Thank you, Piyush, for giving me the opportunity. It's always good to work with you and Chaitanya. And, you know, like you said, hey, even though I'm an endocrinologist, I didn't know and work in AI, I didn't know some of the stuff Chaitanya was mentioning, especially the app and stuff. So that's cool. But, you know, today, right now, my topic is artificial intelligence and endocrine-related tumors, mainly concentrating on thyroid. You know, thyroid, even though it's not as common as diabetes, if you think about it, 1 out of 2 women over the age of 65, actually out of 50, has thyroid nodules. And so that's very common, but most of the time they are not malignant. And nowadays we are finding more and more of these nodules because of a lot of imaging that we are doing, ultrasound, CT scans, and stuff like that. And that's creating a lot of burden in the healthcare system. So we're going to talk a little bit more about all these things in detail. So in this talk, I'll briefly cover how AI can help us in this field to decrease subjectivity It can be used to flag areas for easy diagnosis for pathologists, because if they have a big slide, it'll be great if the AI can flag, hey, look at this area and make sure, this is an area that you want to look. We could also predict molecular markers. We'll talk more about it. AI can be used to stain, slides using different stains than which it was originally stained on. We can also predict aggressiveness or the prognosis of a tumor using AI. AI can also be used as a second read, as a second opinion. And ultimately, we are all getting burned out doing a lot of things. So can we use AI to reduce the time for reading these things and generating reports? So we'll be covering all these things. Now, in the first section, I'll talk about use cases of artificial intelligence in thyroid, cytopathology, and histopathology. So, many a times, if you look at the slides the pathologists look at, even though it's a small slide, it has, gigapixels in it, like a lot of, pixels. And it's hard to go through each area and, pay a lot of attention on it. I mean, pathologists are trained on it, and they go through it and they give us a diagnosis. So what if we can, feed in a whole slide image, and then not select any particular area, and AI can look at the whole slide image and give you a diagnosis based on that. So Rains et al. They did that in thyroid, whole slide images. So what the algorithm will do is, you give the whole slide image. The first algorithm will identify the region of interest, and the second one will classify it into whether it's benign or malignant. And when they tested it, it had a AUC of 0.93, which was similar to an expert cytopathologist, and specificity of 90%. So that's pretty good in the sense that it had good specificity and sensitivity, which is hard to come by sometimes. So this makes it easy. You just feed in a whole slide. It will mark the region of interest and gives you a diagnosis. Now, many a times the difference between a adenoma and carcinoma is, if like one cell cross the capsule, it becomes a cancer. If it's completely inside the capsule, it becomes an adenoma. So that's kind of hard to look at all the capsule all around it. So, AI has been used to make that diagnosis in thyroid nodules. And in one of the algorithms, they use pathologist identified features, morphometric features, and used artificial intelligence to classify adenoma versus carcinoma. And it had 93% sensitive accuracy for the pathologist identified features, and then morphometric features, it was 96% and 87%. Same thing, they have used similar stuff for NIFT-P. So they used keywords. So here they're not using the images, but they're using keywords in the report to separate classic papillary thyroid cancer from NIFT-P. So we are also seeing natural language processing being used in pathology reports to help us in this field. And they were able to accurately differentiate NIFT-P from classical papillary thyroid cancer in 3/4 of these cases. Now, we have been using AI in the diagnosis of thyroid nodules for quite some time. A couple of the molecular testings that we use actually uses artificial intelligence. So what we do is, when we do a biopsy, and if the nodule comes back not as benign or malignant, and if it's in between, we can send it for further testing. And what they do is they look at mutations, gene fusions, and give us a score regarding, okay, there is 90% chance of malignancy. So those molecular markers uses artificial intelligence, and this has been in the market for at least, I would say, 8 to 9 years. So Afirma uses machine learning algorithm to give us predictions for that, and they use an ensemble of machine learning classifiers looking at the gene expression patterns, and they will give us a call whether it's benign or malignant. They have also specifically looked at Hurthle cell and made changes based on the algorithm, because the initial algorithm was not very sensitive to that population. This is kind of showing how an AI algorithm evolved while it was actually being used in the clinical setting to make it even better. So now the other thing is, well, now we have to send these things for further testing, molecular markers, but can we use the information that we already have, the slides, to predict mutations? So that'd be great. We can save a lot of money. We don't have to do further testings. So Fu et al. Did that study, and they used about 17,000 HND stained histopathology slides. And they actually had 28 types of cancer, including thyroid cancer. And they were able to predict whole genome duplication, individual chromosomal aneuploidies, focal amplification, deletions, and driver gene mutation. This is pretty great in the sense that on the site itself, you don't have to send it outside. You get these predictions. Now, again, this is the same paper. They are looking at prediction for Braf mutation, which is very common in papillary thyroid cancer. And just by looking at the slides, the algorithm can tell you whether the patient might have a Braf mutation. So, and predicting AUC, Braf had an AUC of 0.92 in this study, which is pretty good. Now, that is using actual pathology slides. Now we are going even one step up. Can we predict Braf V600 mutations from ultrasound images? So this is not even doing biopsy, just looking at ultrasound images. And Yoon et al. Did a similar study. It was a small study, only 469 patients, and they predicted risk of malignancy, binary output, and the ability to predict BRAF. It was low. AUC was low, 0.64, but this is a promising field where you can look at an image and predict mutations that the patient might have, even before doing biopsies. So next one is actually matching new cases with the curated cases. So if you have a new biopsy, you can compare this biopsy image to previous biopsy images, and pull up all those similar images, and then give a consensus voting based on these similar images. And in this study, they also had endocrine malignancies, including adrenal cortical cancers, pheochromocytoma, paraganglionoma, and thyroid cancer. And thyroid cancer had an accuracy of 96.6%, and adrenal cortical cancers 94.6%, and the rest had 85.7%. When they used similar images and stuff to pull up and make a final diagnosis based on voting algorithms. Now we'll talk a little bit more about the research that I do. So I own AIBX, which is a company now that is trying to risk stratify thyroid nodules. We find similar images. So to me, when I see an ultrasound nodule, I kind of get an impression of whether it's cancer or not, because we've been doing biopsies for a long time. And when I spoke to other endocrinologists and radiologists, they have the same feeling. Even though we have different classification systems, after doing biopsies and getting direct feedback after a long time, you kind of know how a malignant nodule will look like. And we use the same heuristics when we developed AIBX. Rather than giving you a diagnosis of just being a malignancy or whether it's benign, here the AIBX algorithm will find similar thyroid ultrasound images, which has a confirmed diagnosis, and it will give the first diagnosis of the similar image as the diagnosis of AIBX. But the user can also look at other images and the corresponding diagnosis and make a decision themselves. Okay, this nodule looks very similar to the nodule which was benign, so the chance of being it benign is high. This is similar to the algorithm proposed by American Thyroid Association. They give about 16 images in the guideline to match. Our original database contained about 2025 images, so much larger database, and it's ever expanding. We're collecting more data. So that was the first version. And then speaking to other users, they said, well, it's great to have this diagnosis, but can you add more reporting to it? Can you generate a description for the nodule. So we started doing that, and now the latest version gives you a thyroid description and a score, and finally you're also able to get a PDF or a Word report. So this is kind of how it works. You give a test image, and the AIBX algorithm will show you 3 images and the corresponding diagnosis. So the first nodule on the top right-hand corner is the same as the test image, because it was tested on the training data sets to make sure that, you know, it's kind of a sanity check. As you can see, it found the same image, and then you can see similar images with the diagnosis. And I'm a firm believer that you can develop an algorithm and fine tune it to your data and make it look good. So any AI algorithm that we're going to use has to be externally validated. So when we did our internal validation, it had an accuracy of 81.5%, sensitivity of 87, specificity of 78.5, NPV of 93.2. Looks great, right? So then we said, well, this looks good. Let's actually validate in an external data set. So we collaborated with researchers in Denmark, where we used completely different ultrasound images. So they were using supersonic axopolar ultrasound, which we don't usually use it here. And the images, actually, the texture and stuff was completely different. So we wanted to test it on a completely different ultrasound image. And in that, when we tested that, the accuracy decreased, all of these metrics has increased, but we were still able to, get a good negative predictive value. And when we compare this to the traditional way of doing this, it still came out good. So after that, we made improvements in the algorithms, and now we are doing external validation study for a second version. And we completed the study, and the results are pretty amazing. So hopefully we can publish that. Even with that, we still believe in rigorous testing with external data. So if it has to be used in real life scenarios, it has to be vetted from images from multiple institutions, and we have to show that the results actually holds. So it was very encouraging to see the version 2 actually perform pretty good compared to the version 1, even in an external validation study. So hopefully we can share it in the future. Now, there are actually FDA cleared algorithms for risk stratification of thyroid nodules. I think the first one might be AMCAT, which is a Taiwanese company. It gives you multiple risk scores. Then there is Medo Thyroid, which is a Canadian company, which helps with the measurements. It doesn't give you a risk score. Then we have Koyos, which gives you thyroids and a risk score, which is proprietary to them. And Samsung has an ultrasound machine, which actually gives you risk stratification, but they don't have an external algorithm. It just works on their specific ultrasound machine. Now, we'll switch gears and talk about other endocrine cancers. So this is a study in which they looked at pancreatic neuroendocrine tumors and used whole slide imaging to risk stratify these patients. And they found out that they were able to predict a risk of metastasis from these whole slide images with 95% accuracy. That is pretty good for pancreatic neuroendocrine tumors, to the ability to predict these metastasis. Now, another thing is, how can we use it in pituitary adenoma and brain tumors? If you think about brain tumors, the surgeon is opening up the brain, or like going through the your nasal cavity, and let's say they take a frozen section to figure out whether this is cancer or not. And that takes about 20 to 30 minutes to get it out, do the surgery, send it to pathology, and get the results. What if we can use label-free imaging, meaning you're not staining anything, you're just taking the sample out, and you're using stimulated Raman histology and artificial intelligence to make a diagnosis? That seems like really cool. You can get a diagnosis pretty quickly. And it provides intraoperative diagnosis in 150 milliseconds, which is very impressive compared to like 30 minutes of OR time. You're saving that much time in the OR while doing a brain surgery. So they did a multi-center prospective clinical trial, and it showed that it was non-inferior to pathologist-based interpretation. and accuracy was 94.6% versus 93.9%, which is pretty similar. And these studies also included a pituitary adenoma. So an exciting field where you combine, stimulated Raman histology and you put AI together to make diagnosis intraoperatively. Now, anything that we use should also fit in the workflow, right? So Google developed this, artificial intelligence microscope, where the pathologist does not have to change the workflow if they are comfortable, viewing things using the microscope. The AI algorithm will automatically highlight the areas where they need to look at based on, through that lens that they're seeing. So this is augmented reality for microscope. So it will mark the areas of lymph nodes where it shows malignancy and stuff. So it's easy for the pathologist to direct their attention and make a read pretty quickly and not to miss any areas. So this is a good way of integrating AI to the current workflow. And what are the current and future clinical applications? As you all know, there's a lot of hype around, like AI can do this in medicine, AI can do that in medicine. And there is a lot of hope that, we could be detecting cancers before they develop using AI, or predicting diabetes, like before it becomes a problem, like Chaitanya was saying. But we had to figure out what's hype and hope. And we need to do external validation studies and prospective studies to make sure that this algorithm performs the way they are touted to. And there are already FDA cleared software for ultrasound image analysis. Chaitanya already talked about algorithms that are approved for diabetes management. We are already using molecular markers, which uses AI in the background. So it's currently being used in the clinic as we speak every day. In the future, it'd be great if we could actually, use cytopathology images that we do from biopsy, the slides, which are not stained. So we can use label-free, unstained images, to make this diagnosis. There are also a lot of studies where you can actually get an unstained slide and then stain it whichever you want using AI without actually staining those slides. So that's an exciting field. And finally, we need kind of AGI, artificial general intelligence, in these models, which may not be really possible, but at least in this clinical context, combine the clinical picture, ultrasound images, cytology or histopathology slides we have, and molecular markers, combine all this data like a physician does, and come up with a very comprehensive diagnosis. I hope that happens in the future, and I am excited about the future as always. Thank you for listening. Happy to take any questions.
Yeah, thank you, Johnson. That was pretty comprehensive and really impressive work, and congratulations on all the work that has been done with AIBX. Definitely very, very promising. I do have a few questions here in the chat. So we are actually a small group. So Hema, if you want to unmute yourself and ask your question or questions that you had, that would be great.
Yeah, actually, I have, sorry, a couple of more questions. So one was about this paper, Dr. Thomas. You'd mentioned range, I guess it's the last name of someone and all, application of machine learning algorithms to predict malignancy in thyroid cytopathology. I'm sorry, I'm not a doctor.
Yeah, sure. Yeah, absolutely. No problem.
So does that also talk about, I am an engineer by profession, so I'm not in the medical field, but I've recently founded this startup that is trying to go for the holy grail, if you will, is non-invasive glucose monitoring. So that's the perspective that I'm coming from, and I was interested in knowing if this, yeah, you put it down there, if this paper talks about different architectures. I know you've talked about combining two, one's doing the segmentation, and then the other's doing the prediction whether it's malignant or not, or something like that. So does this paper talk in detail about the architecture that was used?
I believe so. I think they used a unit architecture to do the segmentation. I'm blanking on what they used for the malignancy prediction, but I believe that was actually in the article, and I can definitely forward it to you if I have it. I can forward it to Piyush, or if you put the email in, I'll happy to pass that on.
Sure. Yeah, or you could also ask Piyush, because the moment the Zoom call ends, all the chat will be, history will be gone.
Yes, yes.
And I had another question. You'd mentioned something about 16 images. So it's not just classification, like binary classification was not 1 and 0, but something about, I didn't quite get that.
I'll explain it a little bit. So right now, let's say if you're an endocrinologist who follow American Thyroid Association's way of classifying thyroid nodules, you can go to American Thyroid Association's website, and they have the guideline up there. So what they say is, okay, look at these nodules, and there is a spectrum going from benign to malignancy. And in one side, there's a cystic nodule where it looks mostly black. And they will say, hey, this one, if your nodule looks like this, that's mostly benign. And at the extreme end, there will be an image with irregular margins, white dots, which are calcification. And they will say, hey, if you see a nodule like this in your clinical practice, that's probably malignant, right? So that makes sense. So they have these 16 images in that guideline. So that was kind of the standard of care, and still it is. And there is another model where the American College of Radiology recommends a point-based system, TIRADS, which is slightly different. You look at the features and give a point, add up, and then you finally decide to biopsy or not. So the whole idea of these algorithms is to look at these images and decide whether you need to biopsy these nodules. So our algorithm, AIBX, what it does is, so to me, it was easy to calculate, to give a prediction. Let's say we use a ResNet model, come up with a prediction model. If you want explainability, just, drop a heat map on top of it, which doesn't always work, and then call it a day. But if you try to explain that to another physician, they might say, okay, your algorithm says, great, it's malignant. How do I believe it? I'm going to make a clinical decision based on it. So then we thought about, maybe we should make it like how the physician thinks. So, the way I thought about it is, when I see an image or an ultrasound, when I'm doing an ultrasound, I have a database of images in my brain with all these years of experience, and I would say, well, you know what, based on what I have done before, this looks benign, and I can counsel my patients, you know what, it's probably benign, I don't need to do a biopsy. But what if we can digitize this database instead of, our brain and my memory is fallible and my experience is limited. So what if we can, instead of getting that 16 images, expand that image repertoire to thousands of images, and if you give with actual diagnosis, and if the user inputs an ultrasound image, this software can find similar images with confirmed diagnosis, with either by surgery or by doing biopsy, and they can view and then make their own decision. But the algorithm will also give you an output which it says it's benign or cancer, but the user can verify it and make their own decision if they want to. So it makes it more explainable. So that's the difference between having those 16 images and having like thousands of images, and using AI to find similarity and bring up those nodules. Hope I explained it, but if you have any questions, happy to discuss further.
Sorry, the next person has to go.
Oh, no, that's okay.
So one quick question. So your ground truth was always for all these AI algorithms, the ground truth was a 100% accurate diagnosis through surgery?
So there is nothing like 100% in medicine.
Sorry. Again, I'm not from medical field.
No, that's okay. But we sometimes we also ask physicians thinks that this is 100%. I'll give you an example. Okay, so there was a benign nodule which was operated 15 years ago for thyroid, and the patient was told that there was no cancer. 15 years later, patient was found to have a lung nodule. It was biopsied, came back as thyroid cancer. So it's hard to diagnose the follicular cancer. Sometimes you miss it because if it just goes through the capsule in one area and you miss that, you'll call it as a benign nodule. And this patient underwent thyroid surgery and was told that this was benign, but it was not. So that's the best we can do. But now we have other data also. We can use molecular markers, and but the ground truth that we used in our algorithm was either biopsy proven benign, which has a less than 4% chance of being wrong in that sense, and histology, which we get after surgery. So we used either biopsy result or a surgery result as the final ground truth, but it's not 100% accurate. But there are other algorithms which are FDA approved, which they don't even use, that as the ground truth. One of the algorithms uses 1 year follow-up as the ground truth. I'm not sure how good that is. If the nodule did not grow in 1 year, that doesn't mean that it's not cancer, especially thyroid cancer does not grow that fast. So different algorithms use different ground truths, but in our algorithm, we decided to go with the best gold standard that we can get, which is surgery if we can. The next best one is biopsy.
Okay, got it. Thank you.
I have a quick question, Johnson. Great presentation, very thought-provoking. When I was tinkering with a similar task of classifying ultrasound images as benign and malignant, it always troubles me what to do with cancers which do not have an obvious ultrasound characteristics, suspicious characteristics, such as follicular thyroid cancer and subset of follicular variants of PTCs. I think it's rather simple task to train a model which would recognize classic papillary thyroid cancer in ultrasound. It's those images which do not have those high risk features that's where the challenge is. And TIRADS and ATA, they get around of it by just saying, well, if it's low risk appearing nodule, just biopsy if it's more than 1.5 centimeter. Do you think we'll ever be able to use image analysis to accurately diagnose FTCs and follicular variants of PTC? That's
a great question. What Nikita was suggesting was, hey, you know what? This papillary thyroid cancer has a specific look. It has irregular margins, this calcifications. I mean, not everything, but it has a classical appearance. But if you look at follicular cancer, even for pathologists, it might be sometimes, this is the example that I said the patient was told that it was benign after surgery, but it was. And that's even harder to do that from ultrasound. But there was a recent study which actually looked at these ultrasound images, and I think it was published in Thyroid probably last month. They looked at the circumference and they said, well, the more the circle looking or like rounded, which is not typically what we think about, might be actually cancerous. So in the initial stages, it was actually found that, it's easy to recognize papillary thyroid cancer with AI algorithms. But if you add more data of follicular cancer, which is hard to come by compared to papillary thyroid cancer, you would still be hard pressed to make a diagnostic algorithm. So let's say, going back to the proverbial ResNet, to give out a probability for malignancy, they will still that algorithm will still be difficult to predict follicular thyroid cancer because, well, one, the number of images from follicular thyroid cancer will be low. Two, I mean, this papillary thyroid cancer, which is the classical cancer in thyroid cancer, has these specific features, and everything is being pushed down into two sections, benign and malignant. So to answer your question, it is hard to do that way. But think about it in a different way. With similar images, you're actually not giving a diagnosis. You're pulling similar images. So if we have a let's say Hurthle cell or a follicular cancer, and if we have reasonable amount of database for follicular cancers, then it will actually pick up those images and say, well, this was a follicular cancer. So if you are not going for actually classification and finding similar images, you might still find those things. And with the AIBX, the initial algorithm had more papillary thyroid cancer. So when we added more follicular thyroid cancer, we were still we were able to predict a large number of them. Now, will we be able to predict all of them? I don't think we will ever reach that accuracy, because, well, the ground truth is never 100% accurate. Two, there are absolutely benign looking nodule, as you know, Nikita. There can be cystic nodule, which can be cystic papillary thyroid cancer, and that is very hard to actually pick up, unless in our algorithm, if you have a same exact, very similar cystic papillary thyroid cancer. So I don't think it will ever be 100% accurate, but it is getting better in picking up follicular cancers. But there is still more work to do, and external validation for all these algorithms. That's what I keep saying. Hey, you had to, and that other thing is, most of these algorithms are trained or papillary, follicular, maybe a little bit of medullary. But what about metastasis from other sites? What about rare cancers? So unless they have those specific features, it will be missed. But that's kind of true for an expert too. If an expert doesn't know or haven't seen that, there is a chance that it will be missing. That's still a possibility. Another thing to think about it, anaplastic thyroid cancer might actually present without a nodule. It might all look like a diffuse thing, and and a lymphoma. So those are still challenges. But usually the bread and butter things, we should be able to use this to risk stratify. And since those cancers are rare, and one thing I think it should caution, just like the molecular markers report says, just because it said that it's not cancer, if your clinical suspicion is still high, go ahead and do what you need to do and monitor these things over the years. So that's what I would still say. Even if if you have still high clinical suspicion, go ahead and do what you need to do. And if you are like indeterminate, still continue to monitor that.
Thank you, Johnson.
Yeah, thank you, guys. And first of all, thanks a lot to our speakers for the awesome presentation, both Chaitanya and Johnson today. A great discussion about the presentations and the work that has been done. Some great questions over there. But I think it also gives us a lot of hope that I think we are unraveling the future, where some of these tools and technologies are giving us the promise of diagnosing or treating things very differently, just like illustrated in numerous examples today. So thank you everyone for joining us. We will close this session for this month. Please stay tuned. Visit us on brainxai.org and subscribe our YouTube channel so that you can watch the meetings in case you missed them. Have a nice day.